That's sort of is so insidious about any substance that kind of hijacks the reward center is because, like, for example, even in talking with somebody who like in general, the attention deficit, where it's in terms of their executive functioning, like it's very difficult to say, like, I'm gonna do this and then I'm gonna do this, like almost in a like a consistent plan. It's difficult. My daughter tries to explain it to me all the time. She's like, I know you understand the brain, but you don't understand like what's in my brain. And I'm like, I know. I'm like, explain it to me, you know? Um, but so part of what happens in active addiction is it causes this delay in like what would be delayed gratification, right? So if you ask somebody who's in active addiction, like what do you think is like, what are you thinking about, like what you want to do in your future, versus somebody who's not in active addiction, like how, like where do you see yourself like in the future?
This is Rock Bottom with Ryan. No sugarcoating, no filters. The pain, the chaos, the truth. No bullshit. Just recovery.
All right, welcome to another episode of Rock Bottom with Ryan. I'm here with Stephanie and Elizabeth today. How you guys doing?
Good.
Very good. Thank you.
As you listeners know, that Stephanie's been on the show a couple of times now, but we're here to join with her relative and friend Elizabeth. And we're going to get into some different subjects today, a lot of it having to do with the neurological effects of addiction and seeing it through like a different lens. And we'll get into that in a little bit. But first and foremost, let's introduce Elizabeth. Elizabeth, what was your experience with addiction? Do you have a sober date? What was your drink or drug of choice? Where you're
Right.
from? All that stuff.
Right. So my background is, so I am a nurse practitioner, and I sort of got into management of patients who are struggling with addiction kind of by accident. It was kind of random. I'm a NP in nursing homes on the south and west sides of Chicago. And because of kind of how our society is, urban nursing homes are kind of the catch-all for everybody. If you have a patient who, is in addiction and, falls asleep and gets frostbite and they have to have amputations, they end up in a nursing home for rehab. You have patients who are in active use of heroin and they end up with like osteomyelitis or a secondary infection of their wound. They're in the nursing home. So my whole journey for the last 13 years has sort of just been, hey, how do I best take care of this patient? But in order to medically take care of this patient, you have to look at everything. Otherwise you're not going to have a good outcome for the person.
So, so you both are in the medical field in some way, shape, or form. Okay, cool.
Yeah.
There's
Awesome.
lots of nurses in our family on both sides of my mom's side of the family and my dad's. There's a whole bunch of us. If you're going to have a heart
All right.
attack, you should do it at one of our family weddings.
Yes.
Because there'll be lots of people who do CPR.
Life was tough during COVID for both of you then, I guess.
Yes.
Yeah.
So do you, Elizabeth, did you have any sober dates, or like, did you have any specific experience with addiction, or I was just
To say so, like personally, I mean,
yeah.
If anybody says that they have not had at some point in their life compulsive overconsumption, I would say they're full of shit. Everybody has had their own struggles, whether it be, alcohol, heroin, and sugar. Is everybody's a perfect body weight? I don't think so, right? So everybody has a maladaptive coping mechanism. But I do have, like my husband he'll be 2 years sober in February. And my dad struggled with alcohol abuse. So it's in the family. And so, yeah, it's been very, very close to me. And then my own kind of personal struggles with my own maladaptive coping mechanisms, as we all have.
Yeah. I mean, just, having family members and significant others that have struggled with it too. I mean, that makes it a part of you as well. So I totally agree. So today we were going to talk a little bit about the neurological effects, and I'm trying to think of the wordage you used when we first started talking about how you wanted to look at addiction.
Right. So looking at it through the lens of neurobiology and what's going on in the brain. When I have the conversation with patients, like for example, I'll use an example that I had yesterday. I had a patient who was discharging from the nursing home. And when I say nursing home, like again, urban nursing homes, I'm not talking about an elderly person. He's like in his early 50s. And he's been in the nursing home. He didn't have anywhere else to go. They were working on getting him housing. So he'd been there for almost 4 years. And I had been consistently prescribing him Suboxone, and he's been talking about stopping it. And yesterday I had to have a really honest conversation with him and just say, transition times are not the best time to stop. Right. So our goal is for you to not die, because we know that when patients have been in a time of abstinence, especially with something like a benzodiazepine or an opiate, if they reuse, that is their highest risk of time to die, because their tolerance has gone down, they haven't realized it, and they overdose. And unfortunately, I've had a lot of patients where that has been the case. So I just encouraged him. I said, I wrote him the prescription. I said, this is your choice. I respect your decision, but we know that increased stress, times of transition, when you are out of a regular routine, all of those are higher risk times for somebody to reuse, because it just is. Because that's just the way that our brains work. When we are in pain, we seek pleasure. When we have pleasure, our brain tries to compensate back to a level of teeter-totter.
It's kind of like chasing that high, chasing the dragon kind of thing.
Yeah, and I would go so far as to say it's not even chasing a high, because, and that's also part of what we see in patients with active substance use. Their dopamine levels are actually less, right? Because your brain does not want too much dopamine. So that's why you start to develop tolerance, because your brain it has an action of like neuroplasticity, where it shuts down the receptors and it shuts down how much dopamine is released. So when you look at a brain of somebody in active use, they have less dopamine coming out. So the bottom line is, somebody, and I always try to explain this, people don't use to feel good. People use to not feel like shit.
Especially if you're really deep into it, I assume that a lot of that's just why it's a progressive disease. It's just like, oh, I'm
Yep.
drinking just not to be suicidal right now. Or
Right.
yeah.
And there's more and more now. We can even see on like MRI machines, it takes about 4 weeks for your dopamine levels to kind of recalibrate out. I mean, that doesn't count for when there's like cues or triggers for use, because that's a whole different thing. But even for just like enjoying chocolate or sex, or it takes time for just those natural things in life that feel good. They don't feel good until about 4 weeks. So I always just encourage people, at least in a transition period, give it 4 weeks. Just let you kind of just level back out and then reassess.
I'm surprised it's that fast.
Yeah. Yeah.
Is that like
So
a best
approximately.
scenario?
So and if you haven't read it or recommend it, like Dopamine Nation, she's an addiction specialist, Dr. Anna Lembeck.
Okay.
That, like, all things in medicine, right? You can't it's like a multiple choice question, like all,
Correct.
nothing, always, or never the right answer, so like, but for the most part, like 4 weeks ish, right? But then also that doesn't count if then you've then been removed from your usual schedule, and then there's stress that is. So that is a whole other
And
Can you go in?
another layer.
Can you kind of go a little more in depth into like how does alcohol affect the brain's ability to feel pleasure naturally?
Yeah.
I know that's a
So
little bit based on what you just said, but I'm curious.
yeah. So the like most things in nature, the brain wants balance. It doesn't want too much pain. It doesn't want too much pleasure. Pain and pleasure are are in the same area of the brain and within the reward center. So when you have pain, so you're just like when like natural, when you are exercising and they talk about like the runner's high, those are actual endogenous endorphins or like opiates that are being released in your body. And so when there's this natural balance to back and forth, and medications or substances that work on the reward center, whether it be nicotine, heroin, cocaine, amphetamine, those all cause a significant higher release of dopamine within to the reward center than anything else that you can find in nature. Like she mentions in this book, like, for example, like an orgasm, it like increases dopamine by like 10%, whereas like methamphetamine increases dopamine by 1,000. So like one hit of meth is equal to like 10 orgasms, right?
Crazy.
So it and that's why you say like and this also depends on whatever the person's drug of choice is, and that varies depending on genetic predisposition, depending on time, like onset of exposure. So it very much depends, because whatever releases the most and the fastest dopamine is what is the most addictive for that person.
Oh.
Yeah. And so the body does kind of a counterbalance to where, if it's getting all of this exposure to dopamine, it will adjust and block some of these receptors because it wants to stay balanced.
I have a comment on that. That's super interesting, because being a nurse in recovery and having self-reported my DUI, there have been comments and or questions by nurses whose drug of choice was opioids, and that I'm still allowed to give opioids and work in the hospital where I can give them. And there has been comments like, well, you could switch at any point. And I'm like, I mean, alcohol was always really my thing. Like the drugs I was like, whoa, I know that's bad. I'm not going there. So that's very interesting for you to explain it that way, because it never crossed my mind as a nurse, like with narcotics being available, that interested me. It just didn't. So that's very interesting to learn. So that for me, alcohol released more dopamine and I have had narcotics. I've had surgery and I've taken them like prescribed. And I was like, whoa, I felt that rush. And now I know what they're talking about. And I'm never going to feel that way again. So I'm going to stay away from that. Like that's crazy to me that I could separate that.
Yeah.
Yeah, no, like you mentioned methamphetamine, and I accidentally did it one time. I know it sounds ridiculous to say on accident, but I thought it was something else because it was
It
topped up.
happens.
Yeah,
I have a
and
lot of patients who thought they were doing cocaine and they got
that's
fentanyl and they
that's
died.
yeah, that's what.
Yep.
Yeah, I thought it was cocaine. I was like, okay, I've done this before, and the next thing you know, it burnt, and I was like, for that immediate like first half hour rush, I'd never felt anything like it before. But I can't say for like the 3 days I was awake after that, I enjoyed it. But I do recall that intense rush that I had never felt before. And it was like the come down was terrible. And I was like, so basically you just have to keep doing this or stop altogether. I just had a choice to make. And I'm like, I'm just not going to do it anymore because I want to sleep sometimes. So,
Right.
but no.
And they mention too, Dr. Lembeck mentions in the book, there is an equal and opposite reaction. So what goes up must come down, but what comes down into an equal amount down. So like at a negative.
Yeah,
Right.
that is frightening. Yeah. So basically, people just want to keep getting high in order to just maintain, basically. I mean, if I was thinking back at my last relapse when I was sober about 90 days and I was put on this stuff called naltrexone. And I remember when I relapsed, I kept taking the naltrexone. I just remember, I don't know if you know all about that drug. Maybe you do, but I just know
do.
that I
Yeah.
was not enjoying anything about this relapse. I wasn't sick. I was just not excited. I wasn't enjoying my buzz or anything. So I was like, I kept drinking and drinking and drinking. And the more I drank, the more like depressed I felt. I don't know what the effects were because of that medication, but
There's a reason for that.
I didn't do my research apparently.
Yes, there is always, and this is why, like in the whole, I've kind of worked the whole spectrum. Like I worked at Northwestern with, and I took care of celebrities and and then I've worked in like the south and west sides of the city, like I had like retired pimps that I was taking care of, like they're just honest, and to like, just, I like, like, just drop all the bullshit. Like, people are people, and, it's you have to be honest about, like, what you're feeling. And the thing about naltrexone is it blocks dopamine release in general. So that's why you have to be careful with naltrexone, because I've had patients who have reported back to me like, yeah, I don't like get the high, or I don't get a high from using or from drinking, but I also like don't enjoy exercising anymore. Like, I don't get a runner's high anymore. So it basically blocks everything. And so where I've actually seen um more more targeted use of naltrexone is using it when as needed, for like when you're going into a high risk, like high Q situation. So like, let's say you're going to like a work dinner, and that people are gonna be having drinks. Like, take the naltrexone before that. But then, you don't have to take it before that. So more of like an as needed use.
Yeah. Okay. Yeah. Because
That's
I'm
interesting.
yeah, I'm a runner, so like I rely on that runner's high when I go running. I look forward to that reward, and it pops in usually like I run for 45 minutes. It pops in around 25 minutes, and
I'd
I feel
say
like
like
I'm
20,
floating.
like
Yeah.
22. Yeah, yeah,
Yeah, and I'm just like
yeah.
floating. Like I could run another 20 miles if I felt like it. That's how good it
Yeah,
feels. So it's
yeah.
like I remember on naltrexone, I just wasn't getting the rush out of some of the things I used to enjoy. I'm like, I'm supposed to enjoy this whole being sober thing, I thought, but
Yeah.
yeah,
It makes you not enjoy drinking, but it also makes you not enjoy the natural rewards too.
yeah.
So that's a
So
Anything.
that's a
now I
that's a
know,
big
but
cost. Yeah.
so now I'm on a shot called Vivitrol that I get
Hmm.
monthly. So I don't know, I don't feel any side effects from it besides getting a needle put in my buttocks, which is not fun. But I don't feel any side effects though. But I also haven't ever attempted drinking since I've been on it, so I guess that's a good thing.
I took naltrexone also in the first 6 months of my recovery journey because I was not able to maintain it that whole time. Um, and it's interesting because I went through this phase before I got sober of like over exercising and telling myself that I can't drink today until I run and I can't do this. And I still work out. I went to the gym. I did a mini triathlon. I can't be an alcoholic. And so then when I truly did get sober, ever since then, I do not want to work out. It's so bizarre. And so I'm wondering if that like stemmed from that time of like being on naltrexone that I didn't get that reward. And then I just haven't, I intermittently do stuff, but like there's no routine or no gym membership like there was before. So that's interesting. This is very interesting. A lot to
It's
think
also
about.
too, in terms of like, in this is a whole other kind of, when we were talking about like stress induced relapse, is there is more and more data that craving, there is already a physiological response. So it's wanting versus liking. There is already a dopamine hit when you have a craving. So if you have, and it's similar to like Pavlov's dogs, where there's that association. So if you potentially associate now exercise with then having like a glass of wine after exercise, you just
So
may be avoiding that associative. That's a cue.
that's
Potentially.
It's
Potentially.
crazy that you mentioned that, Stephanie, because I thought I was the only one that rewarded myself for exercise with alcohol. And I mean, I got so bad at one point and justified it that like I would wake up 4 a.m., trade stocks, go for my run at like 6 a.m., run 5 miles, and then get back. And I knew the second I got back, I was allowed to have exactly 3 glasses of wine. And this is before work. This is the sad part. And I thought that was normal, and I wouldn't have another drink until the end of the day, like at night or whatever. But that was my reward. And I remember like if I didn't have that reward, there was a few days per month that I was supposed to get urine tested from a doctor in the morning, so I couldn't do my reward. So I didn't enjoy any of it, not the run, no nothing, because I got no reward from it. So it's frustrating. But I hate to admit some of these things, but that's how bad I was when I thought I was functioning drinking.
Right.
So
No,
yeah.
and that's another part too, where, in terms of when we talk about like admitting these things, or like, that's one area of AA that I am a little bit kind of with, in terms of, I feel there's a little bit of a fine line between accountability and shame. You can hold somebody accountable without shaming them. Because if you shame somebody, and I would be curious because you had mentioned in your podcast how you talked about like it was like a hostile environment, right? Like we come from like an Irish Catholic background, so it's like
Mhm.
shut up and do it, like you're fine and what's wrong with you? Like that's not helpful in addiction. It's not helpful at all. Actually, so if you think about the teeter-totter, it just is making somebody feel worse. So then what do they wanna do? They wanna feel better.
Use.
How do they feel better? It's their drug of choice. That's their fast coping mechanism. So I always encourage, and this is something I had to like when my husband was going through recovery, like accountability without shame, because you don't wanna like be like a doormat or just let somebody kinda just continue to just do things that are not okay. But there's a way that you can do that without making it worse.
Exactly. Yeah, without going into too many details, it depends on who I would be talking about, which I'm not going to get specific about. But a lot of the hostile environment, I mean, there were things that were like outright hostile, but it was also just like in short, terse, like just like cold demeanor, not warm and fuzzy and loving. And yeah, I mean, and like I said before, I understood why. It's like, and then you also have to think, as you and I are talking about family members, I don't go to Al-Anon, but I know some things about it. Like, I also see from their perspective what they were going through. And so that, like, always keeping that in mind helped me during that time, and helps me more and to come to terms with it and like resolve it and forgive it and move forward. To look at it from all different angles.
So I had a couple other questions. I had a few questions drawn up here that I wanted to kind of cover. So I saw on your email address it's something about the cortex. So I said, how does alcohol impact the prefrontal cortex in decision making?
Right. So the prefrontal cortex is part of the reward center within the brain. So also prefrontal cortex is where you have a lot of your motivation, your task initiation, your impulse control. That's sort of is so insidious about any substance that kind of hijacks the reward center, is because like for example, even in talking with somebody who like in general the attention deficit, where it's in terms of their executive functioning, like it's very difficult to say like I'm going to do this and then I'm going to do this like almost in a like a consistent plan. It's difficult. My daughter tries to explain it to me all the time. She's like, I know you understand the brain, but you don't understand like what's in my brain. And I'm like, I know. I'm like, explain it to me, you know? Um, but so part of what happens in active addiction is it causes this delay in like what would be delayed gratification, right? So if you ask somebody who's in active addiction, like like what do you think is like what are you thinking about like what you want to do in your future, versus somebody who's not in active addiction, like how like where do you see yourself like in the future? Somebody not in active addiction, the average is like 4 to 5 years. You ask somebody in active addiction and it's like 10 days. So it sort of robs you of the ability of like long-term planning and long-term goals, which is why it's another really, really important aspect of like when somebody is just coming out of recovery, like 4 weeks, like just give it 30 days, 1 month, 4 weeks, and you will start to feel better. And so that's helpful in order to kind of compensate for that hijacking of the prefrontal cortex.
Yeah, I always hear so many different responses because I ask the question a lot, when in recovery do you start to feel better? And I hear everything from 30 days to sometimes 6 months. Some people are really honest about it. They're like, I didn't feel normal till 6 months later. But me, myself, I started feeling better, noticeably better mentally and emotionally, probably after like 10 days. But that was not the case every other time I tried to quit for a couple of weeks because I was already planning on drinking again at some point anyways. So it was just kind of like, I'm going to push this off another day, but I'm going to suffer through it. But this time around, once I quit for good, I don't know what went wrong in my brain, like what went on in my brain mentally, but I just like, since I knew I was never going to drink again, I think maybe it made it easier. So I don't know if it was just my thought process or what, but that definitely made it so that I was just like, okay, I'm not going to have it again anyways.
Absolutely, because also too, it's not necessarily like you're going to feel better after 4 weeks. That's like physiologically, like in terms of dopamine, like other things are going to start to feel more enjoyable. Like you're not going to like the process, because basically right now, like this has been the coping mechanism. When I feel bad, this is what I do,
100%.
right?
Yeah.
So you have to have like another coping mechanism kind of lined up, like what's going to replace that, and that's when we start to talk about like transfer addiction, and is it going to be is it healthy or is it harmful? Like we all feel like shit sometimes, and we all want to feel better. So it's just, if we can go for a run, that's better than doing a line of Coke.
Yeah.
It's better for your body.
It's much healthier. Yeah.
Yeah.
So like Stephanie, when you went through the infamous 13 days and all that,
Yeah.
did you notice even in those like 13 days or whatever, like your brain start to feel it rewiring itself a little bit, or was it just
Um, you know, yes. Um, but I feel like my circumstances gave me like an added bonus as to someone who was just like at home going through this alone. Like I was in jail and then I was in treatment. And so I didn't have it available. So it wasn't really an option. And Elizabeth, like you mentioned, give it 4 weeks. Maybe that's why for some people going to treatment for 20, 30 days is so valuable, because hopefully by then you're like reset. Honestly, I was so distraught in jail that I didn't think I needed to go to treatment again, but I did. And I definitely felt on steady ground by the time that I left there. There was a few times where I thought I could drink this and nobody would know, like if it was something in my house. And then I was like, I was on antabuse. So I was like, yeah, no, I'm not going there. But also, like, just the thought of like, what's a half a beer gonna do? That's not gonna even affect me. So I definitely felt on much steadier ground to deal with those thoughts after so I was 36 days or whatever when I left treatment sober the second time. And I felt much steadier. I mean, there are people who are able to achieve sobriety on their first attempt. That's amazing. For a lot of us, that is not the story. And I definitely feel, for me, I just had to go that one place lower. Like I just had to knock it out of the park to make sure to prove to myself that I could not control this and I could not have one drink. And with that being done, it just like solidified everything that I had learned in AA, everything that I had heard before that I thought was corny and cheesy slogans and whatever. I proved every one of them true. And so that's why I say these things. Yeah. So after the 30 days was definitely on steady ground. It's hard to say when I was in treatment. I don't specifically remember because it wasn't available. Like I didn't have to fight when the option is removed. So
Yeah. And I mean, especially if I just add too, especially with something along the lines of alcohol or benzodiazepines, that withdrawal is a medical emergency. Like that could, I mean, so that is a whole nother layer of, in terms of even just you being in a medically stable place.
correct, which was the
Yeah.
first time that the first attempt to get sober in June of 2020. Yeah. And I
What
did
do you
end up having a seizure. I don't know if I ever talked to you, Ryan, about that, if that ever came up. But when I left, I had been on prescribed benzos for a few months before I got sober. And so I had been mixing alcohol and benzos. And when I left the hospital after receiving a ton of IV benzodiazepines in the hospital, the doctor didn't think I needed a weaning pack or dose, because he said you were on a tiny dose, 0.5 milligrams a day for only a few months. Like you shouldn't have that much of a tolerance. And I honestly did not know. Being an ICU nurse, you don't wean those in the ICU or even in the hospital, really, that I have ever encountered. And so I was trying to be the patient. I was trying not to interject, and I wasn't really in a brain place to do so. So I went to treatment and I was up the whole first night and I thought it was nerves. And the next day in class, when my hand started shaking, then I knew that it was benzo withdrawal. I
Yeah.
also did not know that I had a higher chance of having a seizure from benzo withdrawal than from alcohol withdrawal. I saw spots twice, so I had like 2 aura episodes throughout that day, and then, I was walking outside to pick up my water bottle, and I just went down in rocks and bashed my head and bit my tongue, and so then I got my waning doses of benzodiazepines.
Oh,
Yeah.
jeez. That's frightening that they would even let you leave without tapering
Yeah.
you off, you know, because
Yeah.
I was, you know, not, I don't know if it's cross addicted, but I was taking Xanax for a really long time. I was prescribed it, and then I found a guy who sold full on 2 milligram bars, and I would just buy those all the time just because I could get them whenever I wanted. And I would take
Yeah.
those and drink. And I just remember, like, once I had quit drinking, I kept taking Xanax. And then once I tried to quit Xanax, it was just a whole nother, I couldn't even, like, I had to like lift my hand to grab my phone and stuff. Like my body was not functioning properly. So, very frustrating. But
I don't know if
so
you wanna,
now if I go to the doctor, there must be a note in there, because I had, even not this time since I've been sober 16 months yesterday, but like in all the times that I saw new doctors and psychiatrists, I would always ask, you know, can you please put me on lorazepam or clonazepam again or whatever? And I would say it so casually, and they just would immediately say no. So there must be like some lifetime note that I can't take them.
there is that, and Elizabeth
There's
can probably touch on this too. There's a
yeah.
whole push along with the opioids to decrease prescribing with benzos and recognizing how dangerous they are, how difficult they are to wean, how terrible the side effects are. And I'm sure Elizabeth can give us more details on that.
Yeah, I'm very careful. Like I'm kind of like the suit man when it comes to like controls. Like I'm not anti, like there's definitely a time and a place. I have a lot of patients who like I'll prescribe just like 5 tablets of Xanax, like because they know when they're getting on a plane, they're going to like have a
Right.
panic attack. And even just having the bottle, like with a couple in there is enough to like ward off the panic attack.
Yeah.
So like little strategies
Like a
like that.
crutch.
Yeah,
Hmm.
like it's like an adult safety blanket.
Yeah.
But
Right.
but they don't use it, and that's the point. Is like it's just having it there is enough to know that they're not going to have that panic attack.
Right.
But yeah, I consistently, when I see a new patient, I consistently always look at the Illinois prescription monitoring program, and all the states have them. So whether you're in Illinois and actually on the website, you can also check like surrounding states. And, it's not this like, I gotcha kind of, it's, if I see a patient and on their monitoring program that they have like 4 or 5 different prescribers, uh, a crossover of benzodiazepines and opiates and like oxy and all of that, Ambien. My initial isn't, and I think that's changed too. I'm not like, oh, this person just wants drugs. Like I honestly, my initial thought is this person's not good. Like something's going on here. Like we're gonna have to like have an honest conversation about like what's going on, because addiction 9 times out of 10 is a secondary diagnosis. What is the why is the person, why, like what's the reason for why this person feels bad all the time? Or is it depression? Is it anxiety? What are they trying to manage? And so that's how the conversation needs to be approached, in that like not what's wrong with you, but like what's going on? Like there's this does not look good, and your brain's not in a good place. So like what do we need to do?
I think I was that 1 out of 10. Really? I do. I do. I'm like, I've evaluated my childhood and I've evaluated all these things. And I'm like, I think genetically, I was just born to be an alcoholic. I don't know. I've thought about it. Maybe I'm wrong, or maybe I'm into.
I'm sorry, but I'm going to have to call bullshit on that, because especially the fact of like, when you're a nurse, all nurses have some level of PTSD.
Okay, so I did discuss
Okay.
that.
Yes.
Okay, good one.
And
You got me.
and this was even when you had mentioned this was like December of 2020.
COVID.
Like who wasn't, like we were
Yeah.
all on our own.
But I'm talking about for like in my 20s, like before, yes, I was a younger nurse, but I was out with the party girl mentality and I wasn't drinking every day. So yeah, I don't know. Maybe there's definitely some PTSD from nursing, if not from other things.
Yeah.
Okay, she got me.
Yeah. No, I mean, I think, I mean, trauma is relative, but I mean, I just feel like a lot of us in addiction, I mean, I talked to so many people who became addicts and alcoholics, and it's like everybody has some form of trauma. I mean, even if it's your parents getting divorced when you're under 10 years old, it's like to some people that maybe they, moved on and everything was fine, but some other people that broke them, so it's just
Yeah,
things like
that's a
that.
yes. That's a yes on an ACE score. So I ask that quite a bit. It's the adverse childhood adversity score, just because there's a correlation. It's not causation, but there's a correlation between um, uh, an ACE score of a 3 or above with mental health struggles, substance use disorder struggles, just because it's 10 questions. I would encourage people to kind of take a look at it, because we know now that things that happen in childhood do affect your later life. Your brain is wired in early childhood, to the point to where now they're talking about the cry out method, how like that's like the worst thing you can do.
Hmm.
So yeah, we're learning more, and that yeah, kids are not born resilient; they are made resilient. But that doesn't mean that trauma hasn't affected them.
Yeah, exactly. So I had a question, since Stephanie and I have both probably experienced a lot of blackouts in our past. I would assume I have. I know I have. Are blackouts a memory issue or something else neurologically?
Oh, so the alcohol affects your cerebellum, which is also, so it's within your brain in terms of it's also a CNS depressant. So, it just knocks you out, but also for the cerebellum is all like your motor function. So that's why like your gait is off and all of those things. So
Yeah.
it's all neurological.
Yeah, because
Doesn't
I
it
was.
prevent something from transferring from short-term memory to long-term memory?
Like in terms of what?
In blackouts, doesn't the alcohol prevent remembering things in your long-term memory? Yeah.
Honestly, I don't know.
Okay.
I don't know. I'll have to Google that. I'm not sure specifically about like blackouts. But I
Yeah.
just knowing that it's a CNS depressant,
Right.
and then that, and to what level for what people that gets to what point, and
Yeah.
then yeah, there's some variables to that.
Yeah, because when I
Drowning
would
out.
be drinking back in the day, or even obviously even just 2 years ago, it was always a certain point when I would just know I would lose all recollection of the entire night. So I just never knew like when that switch gets hit. Just because I drank a certain amount, my brain just couldn't comprehend it anymore, and it just wipes everything out after that. Or is it
Mhm.
just, can it happen with any amount of alcohol? It's just whenever your brain can't handle it, or I don't know. So,
Yeah, I mean, honestly, I would honestly want to look that up, because in terms of like what's going on, and specifically with alcohol, in terms of it being a CNS depressant, a central nervous system depressant, and then like which specific different areas.
yeah.
Um,
Okay. Can cognitive function fully return after long-term alcohol abuse, do you think? That's a question I want to know, because I still feel like myself getting better every day, but I want to know I'm going to keep getting better 10 years from now.
yeah, I would say I see recovery. And then I do see a fair amount of dementia, like ETOE, alcohol induced dementia. This is over a long-term period.
Is that wet brain?
Is wet brain.
Wet brain.
Hepatic encephalopathy.
No, that's related to, that's a little bit different. But in terms
Oh, okay.
of, the ETOH induced dementia is just one of those branches of cognitive deficits and decline, but it's usually also multifactorial. There's usually like some vascular things going on. We all have plaques growing in our brains. Like everybody has, some. But I would say that there is recovery. The brain is an amazing organ. There is neuroplasticity. It can compensate. It can relearn. And yes, I would not underestimate what the brain is capable of.
Yeah. Wet brain is a layman's term for hepatic encephalopathy, which is your
Got it.
liver and the ammonia building up because your liver's not functioning properly, and how the ammonia affects your brain. And that's why your brain is not functioning properly, which we see a lot in the ICU. People come in like, and the medicine that we give to treat it makes you poop. And so people are like, "Oh, I was pooping. I stopped taking it." We're like, "Yeah, Well, and then you're not responsive and you're not breathing appropriately. And so then they come in for, altered mental status. So it's a big,
Wow.
terrible cycle and circle.
Yeah, I was
Yeah.
always
The
wondering
medicine that we
that.
give binds to the ammonia in your gut and then you poop it out. And so people are like, oh, yeah, I stopped taking it because I had diarrhea. We're like, yeah, that's what
The
it's supposed
diarrhea,
to do.
the
Yeah,
keep taking your
great. And
keep
then you come to
taking
the
your
hospital and
orange
then we have to deal with it and fix it.
Oh,
keep taking your orange syrup, your
Right?
lactulose.
Yes.
wow.
Sorry, Ryan. Nurses have a sixth
They're
sense
so
of
No, you
sorry.
humor.
guys, no, you guys have no so much knowledge about this stuff. I have millions of questions. So, um, so let's see. I was gonna ask, what neuroplastic changes happen when someone stays sober?
I would say in terms of one, you're no longer introducing the damage, right? So like when you say you're like somebody is smoking or doing, whatever, now you at least are removing the problem, right? So at least now it's not going to get any worse. But then in terms of, I'm sorry, like perimenopause brain.
I did too. Oh, man.
That's
What
funny. I'm
I
interviewing
Right.
somebody about that.
That's a
At,
whole nother
right? Oh,
podcast.
yeah, I just reached out to somebody last night about perimenopausal brain. I had no idea what it meant, but she's also sober, so I'm like, let's get into this.
it is such a thing. Like, oh my gosh, 43 hit. And I was like, oh my God. Cause it's like my superpower is like being able to just like rapidly recall like patients, like nurses will call me and it's like this patient, I'll just like be able to remember their meds and stuff. And now I have to look stuff up because
Yeah,
it's going
I get
on.
it.
It's real.
Yes.
It's
It's
real.
Talking
so
to
real.
a couple of alcoholics, we're on the same page.
In terms of just like the brain functioning, but also too is the therapy going into why you're using in the first place. That getting kind of diving into that primary diagnosis of like why was I using this as a coping mechanism? Where did this stem from? And that's also a big part of why, patients who undergo gastric bypass surgery, if they don't have the right therapy, 1 in 4 patients then go on to become alcoholics because they've just transferred whatever their
Yeah.
coping
Addiction.
mechanism is. Yeah. So it's just a transfer addiction. So I would say in terms of maintaining that and like overall brain health is also putting in the work to understanding why you're doing why that started in the first place. What am I what's going on? Why am I feeling bad where I feel that I need to feel better? Because that's the basic teeter-totter of the pleasure, like the pleasure.
Yeah.
So interesting.
Yeah. So I'm sure Stephanie's probably experienced this too, but like the reason we kept drinking a lot of the time for me was the anxiety. Obviously, the waking up, feeling just heart thudding, shaking. I know the physical effects, but even mentally, I felt like I needed it. So, like, how does alcoholism like worsen anxiety and depression neurologically?
Right. So my question would be is then is is do you feel that there was always some level of underlying anxiety? Do you feel like there was always some either like social anxiety or like anticipatory and that's what I'll go through and you'll do like a PHQ-9 score or a GAD-7 score, which is just kind of getting a basic understanding of like what is there some baseline anxiety that we're in. And this is why so many patients with mental health struggles, depression, anxiety, their teeter-totter is already tipped to the side of pain. So that puts them at higher risk of substance use disorder. But so my question would be then and for patients who are in recovery, for whatever that initial symptom was, that whether it be anxiety or depression or low motivation, what can we do to manage that in a healthy way? Is that something that we do through therapy? Is that something that we do through alternative coping mechanisms? It would potentially some extra circulating serotonin be helpful, and that's where like the SSRIs come in. Whether like Xanax or not Xanax is not the one. Zoloft or the Prozacs, where you have the increased circulating serotonin, which actually manages the anxiety. You're not just band-aiding it.
Yeah, I'm on Prestique. I don't know if that's one of the
Yeah.
SSRIs. So
Yeah, so Prestique it's actually an SNRI, so it works on both serotonin and norepinephrine. So serotonin is sort of your mood, kind of lengthens the wick on like when you lose it or like you just don't feel that angst. Serotonin, like that's what serotonin is really good for. And then norepinephrine is one of your kind of within the catecholamine system of like your motivation. It works similar in terms of kind of with in the branch of dopamine in terms of like increasing motivation, drive, focus.
Jane. Okay.
Mhm.
And Stephanie, were you suffering from any like anxiety, depression prior to drinking, during drinking, and like were you drinking on medication and it just wasn't working because you were
Yeah.
drinking?
Yeah. So it wasn't until the last 2 years or so when the drinking really progressed and really picked up that I started complaining of anxiety. It was like I also had alcohol-induced insomnia. So I'd fall asleep for 4 hours and I would wake up at 2 or 3 in the morning, like dry mouth, heart racing, knowing I had a whole day ahead of me in work. And so I started complaining of anxiety, hoping to get benzos. I'm going to be completely honest. I manipulated my young doctor into prescribing me benzos after months of trying sertraline. She even increased the dose, and I went back and I said, I just need a short acting benzo like the Razapam, like because I knew I didn't want Valium because it's long acting. And she said, okay. And I was like, whoa.
Yeah.
Okay. I mean, she also told me that she learned a lot from me after I was honest. And yeah. I was like, yeah, I bet you did. She's like, I'm not going to get manipulated by some ICU nurse ever again. It's not funny because I ended up having a seizure from it. But like, it is to show how manipulative we can be and how like cunning and baffling. And I didn't purposefully keep it a secret that I was on these medications. Afterwards, my parents didn't know, my family did not know that I was on either of those medications. I have never had depression or anxiety until it was alcohol induced. So like it says that on my chart and I'm like, can you take that off? Like that's not me. And then after treatment, I was on 2 antidepressants and I was catatonic, like could not function. And it took me months to figure out what was wrong. I was not functioning properly. It felt like my brain was slow, like the neurons were not firing and connecting. And it took like a month after I weaned myself off sertraline. I talked to my doctor about being weaned. I'm awful. I knew you had to be weaned off. I knew you couldn't
Yeah.
cut it off cold turkey. So I was like, okay, I'm going to go from 150 to 100 for a week to 50 for a week to 25 for a week. And then a month later, I was like, okay, I'm done. And then I went to my doctor for my checkups.
That's all right.
And
I
he's
tapered
like,
myself off
"Are
Adderall.
you
That was a
medicine
horrible
Yeah.
going?" And I was like, oh yeah, I stopped that. I don't need antabuse anymore. I don't have any craving. Oh no, I stopped that. And he was like, I was like,
He's like, without consulting
I'm
me.
I'm guilty because I took sertraline for a while for PTSD because like I was losing my shit on my kids coming home after COVID,
yeah.
bringing that shit home. But my gosh, like the blue balls that sertraline causes, just like I prescribed it to this one guy. He was like, I don't know what that is. He's like, but I understand why it's a little blue pill because it like
Yeah.
it really like prevents orgasm. It's terrible. But so I switched over from sertraline to fluoxetine and like that totally resolved. So that's when I went in, I was like, actually, can you change the prescription because I'm not taking
Right.
that one anymore. So I'm guilty. I'm guilty.
We tell them what we want. This is what we would like for you to order.
Yeah.
No, I was on
Okay, good. You agree?
Paxil.
You're
This
great.
Paxil
I'll
is similar.
keep you, Doc.
And
Yeah.
Paxil, I
Paxil's-
remember,
yeah.
had horrible sexual side effects that I remember. I
Yes.
was so frustrated that I didn't even taper myself off. I just stopped taking it. And I remember I went through this whole depression phase, stayed in my house for like 2 weeks until I kind of started feeling better. But I just remember the blue balls, the sexual side effects were horrible. So, I mean, I know that's common amongst a lot of antidepressants and stuff like that. Sertraline, I think I took that as well. So, but it's like I drank on every medication I ever took. So I never really gave them the opportunity to actually work or function.
Right.
Right.
This is the
And
first time in my life I've been on stuff that I actually allowed to function. And now it's like I have no less anxiety and depression than I had before I even picked up a bottle. But what were you going to say?
no, just making sure that, you had mentioned that, when you had anxiety when you were younger, like it's so important to make sure that that underlying, whatever the mental health struggle is, managed, because that will also then help the person stay in recovery because they don't feel anxious anymore. They don't feel depressed. And whether that be with a medication or whether it be with therapy, it doesn't, but it has to be managed in some way. Otherwise, it increases the risk of the patient relapsing.
Okay.
And that is what we do now.
One more question about medication. Why I've noticed when I was in treatment and a lot of other people I hear in recovery take gabapentin. Why is that so commonly prescribed to people? When I thought it was like a nerve drug, but now it's like
Yeah,
given to all these.
I'm not a huge fan of gabapentin except for like I use it in like my diabetic patient populations, but it's an opiate potentiator. So basically what it does is it's just another, not as bad as a benzodiazepine, but it increases the risk of accidental overdose because of respiratory depression, because it heightens the sort of like Benadryl. So you hear people taking Benadryl with an opiate, it that's a potentiator. It heightens the high, but then it lowers the low, and then also increases the risk of accidental overdose. So I tend to not use it in like younger. I will only prescribe gabapentin for typically for neuropathy type pain related to like diabetes or peripheral vascular disease, not in a
They gave it to me at treatment too.
mm,
Yeah, when I first got there, and I had been fairly argumentative at the first treatment facility that I was at. Um, and going to the second treatment facility, I was like, I am going to do everything they say. I am not going to argue. So when they brought me in the meds, I was like, I don't take Neurontin. I was thinking about nursing. We go through their med list and they get their home meds. And so I said, that's not one of my meds. And then he said, oh, it's just part of the routine. I said, oh, okay, okay, I'll take it. I
okay.
was like, but it was only 5 days or something when I
My
first got.
question to that is, and I don't work in acute recovery.
Right.
So I'm not totally up to speed with that, but potentially would they give gabapentin initially early on, because it's an anticonvulsant. It's an anti-seizure medication. So do they use it in treatment to reduce, I mean, it's not the best anti-seizure medication. We use
Yeah.
other things, but was it behavioral or was it for medical reasons?
I thought I mean, I know what it does. They're like, oh, it'll calm your nerves. And I'm like, I mean, okay. I'm used to giving it to peripheral vascular and neuropathy pain patients mostly as well, or chronic pain, some people. So that's why and my dad had taken it prescribed for nerve pain, and he said it was hell to be weaned off after surgery. And so that's why I was like, ew, I don't want that. But I mean, they weaned me off it, and I wasn't sure if it was just to, like, settle you in the first few days of being in the new environment, and I wasn't at risk of a seizure then because I had not been drinking or taking benzos
Mm.
continuously. This was right after I was in jail for 6 days and went to treatment, and when I got there, they gave me Neurontin. And I do see it fairly common, like, when patients come into the hospital that they're on it as outpatients.
Yeah. I'm
But it also could
prescribed
be the diabetes, like, who knows?
I'm prescribed 3 a day now as needed, but I mean, I rarely ever take all 3. So, I mean, but I don't even know if I'm taking them for anxiety sometimes or what, but I don't have that much anxiety. So I just kind of, let them pile up, I guess, and keep them on hand. But I just was always wondering just because they seem so commonly prescribed to people. So,
Yeah.
how do you tell the difference between underlying mental illness and alcohol caused symptoms?
It's,
Good one.
I know I'm coming at you with some questions, but if you I don't expect you to have every answer, but these are things that I wanted to cover for sure.
right. You have to take time with the person and talk to them. So when I have stay in your cortex, which is like the practice that I have at that I'm an independent contractor at Ardent Counseling Center, and this kind of came up kind of randomly. Like I never had this intent of having a practice, but the patients that I saw in the nursing home then were like, I don't have anybody to see like when I leave. And most psychiatric mental health, they are very particular about what insurance they take. So I'm very like I feel morally and ethically obligated to take I will take private I take Medicaid, private pay, like I will work with people and that's kind of like my main priority. But then it just happened to where then like more and more people started coming. So then I needed to like make it an LLC because I guess I was getting killed with taxes. So, I started something for a good reason, then and it just turned up to be something, good and for my living. But when somebody comes into my practice, I always start with past medical history, past surgical history, social history, their ACE
Mhm.
score. As I mentioned before, the adverse childhood events, their PHQ-9, which is their depression screening, their anxiety screening, because you have to get the whole story of kind of what makes somebody tick in terms of both medically and their social, all of their socioeconomic or social, all of those dynamics matter because it's understanding why this person, why like why is there this need for this coping mechanism, or what is pushing what is pushing the patient to use alcohol rather than this, what are their cues, what are their, in terms of like their evocative cues or their triggers. So you have to learn all of those things and it takes time, and a lot of providers do not give time, and which is why therapy is really important, because you may not get what you need from a medical provider, but a therapist then working. So I work a lot with the therapist within Ardent. We talk back and forth because they get an hour. I don't get an hour. So we'll communicate back and forth kind of new things that are going on with the patient, stuff going on in the family. And so all of that matters because I don't want to just be throwing drugs at a problem. I had a woman, her husband or her son died of an accidental overdose, and she was going through situational depression and anxiety, but there's no medicine for that. And I asked, like, have you noticed like an increased use of wine? And she's like, yeah, I have like noticed like an uptick in my drinking. And I'm like, okay, like, so do you feel like a medication would be helpful for that in terms of, or do you want to just continue therapy? Because obviously she's grieving and she's in a lot of pain. And so she's coping. So, but she wasn't depressed or anxious in the beginning. Sort of like what Stephanie said, she didn't have
Yeah.
like a baseline,
Yeah.
but this is very situational. So maybe at that time, we did a short-term use of an SSRI, and that kind of helped her sleep a little bit. I used hydroxyzine instead of alprazolam. That would help her sleep, but also just recognizing like there's nothing to say that I have a medicine that could fix this would be doing
Right.
a disservice to you, because it's not. But how can we keep you functioning? And that's
Do
the
a lot,
goal.
do a lot of people come into your practice in denial about how they think anything from childhood, even if people are, in their 50s and 60s, they function their entire life, with whatever happened in their childhood. Do people come in and kind of in denial about how that might be affecting them?
It depends. There's
Yeah.
a large cultural aspect to that. You will not get an Hispanic female to like tell you anything, like everything is fine, right? Like there's definitely like a cultural aspect to things of, what are you just going to like grin and bear it? And, things that but we were only one generation removed, at least Stephanie, from World War II. So I have actually, if I have patients who, you know, came from Poland or who immigrated here and they're first generation, they have generational trauma going on. They dealt with the Nazis and they dealt with communists. So like we're not far removed. So you have to get all of that history. And sometimes you have to pull it out of
Mm.
the older generations.
For
That's what
sure.
I would assume. Yeah.
And because they're a little bit more stoic, not all the time, but more hesitant to feel like they can talk about it, that they should just be fine. I should just be fine. I shouldn't need this. But
Yeah. Those
I can
generations tend to
usually
be, yeah.
pull it out of them.
Yeah. No, I know. Those generations, I guess, think are a little tougher to break. They're just,
Yeah.
hold their head high and it's a little more stubborn sometimes and just don't want to admit that these things are affecting them.
Yes, but then it is, and they're usually using a maladaptive coping mechanism, like
Mhm.
they've been drinking, or they've been, you know, overworking their whole lives where they don't ever take time to stop, because if they ever take time to stop, then they're going to be in their thoughts. And so I just have to keep going. So it doesn't even have to be a substance. It can just be a maladaptive way of living.
Stephanie, in your case, like, did you start to realize longer into your recovery or even early recovery that things from your childhood, which you don't need to get into if you don't want to, but it just
Yeah.
did you realize some of those things were impacting you, and like how did you use that to strengthen your recovery?
Sure. The second treatment facility that I went to 5 years ago dug deep into PTSD and trauma. And I did talk about some of the nursing stuff. So Elizabeth totally called me out correctly. And I did dive deep into that stuff. There was also stuff that I had never, ever talked about, not from my childhood, but like in my 20s related to drinking. So there was definitely some work. And I told my therapist there, I was like, oh no, I had a great childhood. Like my dad got sober when I was 12 and everything was great. And she was like, yeah, let's dig a little deeper into that. And so we did. And my family, my parents were amazing, but there's definitely, no matter how strong of a woman your mother is or how strong of a united front they present, there's definitely things that kids pick up on. And so there were things that, maybe that I had picked up on, which I never would have thought unless I was told to like dig deeper. But I still don't think it was severe or, I mean, there's definitely worse situations that children grow up in. I mean, I didn't even think it was a problem. So, but digging deeper, yeah, there are some things, but I let go of that. I felt like, okay, I had been struggling for 6 months to get sober, and this is it. Like, I need to do this now. Whatever is in my brain that's holding me back, whatever I'm holding on to, whatever past trauma, garbage, dark stuff that I need to get rid of, I talked about it there. And I made sure I did. And I left it up there in those hills up in Wisconsin. And
Yeah.
so I really felt, and then plus while I was there, I was on the phone with my sponsor working the steps every single night. So I did my fourth and my fifth step. So during that time, it was really like a massive release of so many things. And there was somatic therapy and it was really deep, deep interpersonal work. And I really took advantage of every opportunity that they had to offer. And so when I came out and I took advantage of that time because I knew when I was coming out, I would be going back to work and taking care of my children and going back to life. And so I knew that was my opportunity to take full advantage of everything that was given to me. So once I was 35 days sober, I came out of treatment like ready to start making my amends. And people were like, yeah,
Okay.
no, not yet. So I
Mm.
just kept working at, talking to my sponsor and all that. So it wasn't for me because I had already tried getting sober. I knew what I was doing wrong. I
Yeah.
felt my sponsor and I knew what I was doing wrong, and I did everything I could to correct it. Yeah.
Yeah. No, I totally get what you mean. Talking about like you're riding that high of becoming sober and starting to feel confident and motivated and stuff, and then trying to make amends too early, and it just kind of ruins the high a little bit when people aren't ready for it, you know? So that happened to me. I was making phone calls from my, 1 hour gap at night in the evening to make some phone calls and try to rekindle some relationships. And they're just like, dude, you were blacked out for 3 months less than a month ago. Like, what are you doing?
Gonna take a little bit longer.
Yeah,
Yeah.
I'm like, "Okay, I guess I'll wait till I'm out of here at least." But no, it's
All right.
just a couple other closing questions. What's one neurological fact about alcoholism and addiction that would reduce shame?
One thing that sort of came to my mind, Stephanie, when you were talking in terms of your experience with the doctor of like manipulation and cunning. Be careful with the self-talk. Right? Like manipulation and cunning, like those are negative things. So like seeing it in a way of when somebody is in active addiction, manipulation is just a survival tech. And so that person is doing what their brain feels they need to survive. But that doesn't mean that you are a manipulative person or a cunning, right? Right?
Correct.
Right.
Yeah.
So, but also too, like you are further out for people who are just, still kind of, earlier on in recovery, be careful with your self-talk, because you may be saying things very negative to yourself that are not helping. Like you're almost even self-shaming yourself. So the most important thing is holding yourself accountable, but without shame. Because there's a quote, and I have it in my office, but that a person struggling with addiction is another perimenopause, but a person with addiction needs shame as much as a thirsty man needs salt water. So it is what people may think is being helpful or being tough love. The intention may be good, but it may not only be not helpful, but it may be.
Okay. Yeah.
So,
No, that's why it's like when we're in recovery, it's like the last thing we want is any negativity or people shunning us or
Yeah.
bringing up old things. And it's like, yeah, I know, but look at me
yeah,
now.
yeah, yeah,
Yeah. I definitely don't feel that way now. I was
Yeah.
saying those behaviors then in active
Yeah.
addiction. Yes.
right.
Looking back, I was like, wow.
Hmm.
Yeah.
Yeah. I can take criticism now
But
better than
definitely thank you for
never.
clarifying for people in earlier recovery. Like, I'm not saying, yeah, I didn't mean it that
Yeah.
way.
Yeah,
Of
no, but
course.
it's easy to sort of get to that place to where,
Yeah.
and I see that with people talking when people are talking to me about like this patient that I just discharged from the nursing home, like he didn't feel like he should have to take it. Like, and he also felt like, oh, if people see that I'm taking Suboxone, it's that like I'm not like I'm still using.
Yeah.
But, you basically have to be like, well, like what other people think, like if this is going to keep you from dying and overdosing and you need to take it for like a couple of weeks while you're in a transition period and you're
Yeah.
getting kind of your bearings back, then who cares? Like just, and people need to hear that. People need to hear that it's not because they're bad people or it's not because they're weak. It is the brain. And
Right.
these drugs are insidious and you have to give yourself a certain amount of grace.
Huge amount.
If someone in recovery could understand one thing about their brain, what should it be? It's my final brain question.
I would say explore why you're doing what you're doing, because there's always a reason. And if I could recommend like the two books that I recommend the most are What Happened to You. It's by Dr. Bruce Perry. And he basically studies trauma and the concept of the book is we shouldn't be asking people what's wrong with them. We should be asking people what happened to you, because there's always a reason why. And the second one is The Dopamine Nation, because it explains what's going on in the brain in the process of where they say, well, like addiction is a disease. And people will say, oh, no, it's not. It's just because people they just want to get high. No, it is. It is a process that, and now too, thank goodness for increases in technology with MRI scans and we can see this. This is a medical process. This is a physiological process. So it is not a character problem.
Defect.
It is
Right.
not your character. This is a medical issue that needs to be addressed, and anything else that would need to be addressed medically, like high blood pressure or diabetes. So it's not because of your weaknesses or your faults. It's something that needs to be taken care of like anybody else with a medical problem.
Well said. I would love to know what each of you, what final advice would you like to give to my listeners that are out there struggling right now, that are sober curious, they're new to recovery or not in recovery yet, but getting there? What advice would you guys give?
Mine never changes. Don't quit 1 second before your miracle happens. There's so many things that we've discussed and reasons and things to explore. Just don't give up. Keep chasing it. If you can't get it right, you never know when it's going to stick. You just never know which time it's going to stick. So keep trying.
Yeah. And I will add on to that I encourage people to reframe the thought of, I wasn't successful in this attempt. I wasn't, I wasn't able to stay sober. Each time you try is a learning experience. So you can say, okay, this worked for me. This didn't work for me. Okay, next time, maybe I need to avoid these situations because that was for me. I'm not ready for that. Or this was too much of a cue for me. Every time you try is a learning experience, not a failure.
Love that.
Amen.
Stephanie, do you have any other questions for Elizabeth or myself?
I do not. This was great.
This was fun.
Yeah, I'm super happy that we all connected.
Me too. No, thank you so much. That gives a whole different perspective on what we generally talk about on the show. So hopefully this gets people to kind of read into a little bit more and maybe not shame themselves so much about their own decisions, and that there's so many neurological impacts that affect
100.
our addictions and how much they progress. So really appreciate this perspective. So thank you, Elizabeth. Thank you, Stephanie, for joining the show.
Thank you.
Thank
Appreciate
you so
it.
much. Bye-bye. Take care.
Bye.
Thank you.
Rock Bottom with Ryan. No bullshit, just recovery.